Good morning, Lisa. Can we do a mic check, please?
Hi, can you hear me?
Yes, thank you very much.
Thank you.
Good morning, Evelyn. Can we do a mic check, please?
Good morning. Are you able to hear me? This is Evelyn.
Yes, I can hear you. Thank you. It's my understanding that you also have a screen share you want to test?
Correct.
Okay, whenever you're ready. It's working.
Great. Fantastic.
Great. Thank you very much.
Thank you.
Good morning, Lorene. Can we do a mic check, please?
Yes. Do you hear me?
Yes, thank you very much.
Sure. Do you want to check whether my two slides will come across?
Yes, please. Let's go ahead and do that.
Okay.
Whenever you're ready.
Okay. Okay, down there. Do you see those?
Yes, we can see them. Thank you.
Okay, thank you.
Hi, Renee. Can we do a mic check, please?
Hi, good morning.
Good morning. Thank you very much. Good morning, Supervisor Ellenberg. Let's do a mic check whenever you're ready.
Good morning. Is this Dave?
Yes.
I don't see your name there. Oh, clerk of the board.
Oh, yeah, I'm signed under clerk of the board, and Jess is going to be your clerk this morning.
Okay, great. Thank you.
Thank you.
Hey, Renee.
Good morning, Supervisor. I was on mute there.
Good morning. Just a reminder that our broadcast is currently live.
Good morning, Sherry. Can we do a mic check, please?
Yes, good morning. This is Sherry Terrell.
Thank you.
Thanks.
Good morning, Doug. Can we do a mic check, please?
Can you hear me now?
Yes, thanks very much.
Great, thank you.
Good morning, Mr. Rutherford. Can we do a mic check, please?
Hi, George Rutherford, 54321.
Thanks very much. Good morning, Dr. Smith. Can we do a mic check, please?
Yeah, I'm here. All right, can you hear me?
Yes, thanks very much. Good morning, Paul. Can we do a mic check, please?
Good morning, this is Paul.
Thanks very much. Good morning, Miguel. Can we do a mic check, please?
Good morning. Can you hear me?
Yes, thank you. Good morning, Supervisor Simidian. When you're ready, let's do a mic check, please.
Thank you. I think we're loud and clear, but you can confirm that for me.
That is confirmed, sir. Thank you.
Thank you. David, I'm going to ask you to just let folks know we'll be delayed just a minute or two. I'm going to go to mute. I'm going to stop my video, and then I'll be back in a moment or two. All right?
Understood. Thank you, sir.
Thank you.
Will the individual with the phone number ending in 037 please identify themselves so we can do a mic check?
Hello, this is Laura Rosas, CEO of VHP.
Hi, Laura. Thank you.
Hello, thank you.
Good morning, everyone. This is just a reminder that President Simitian will be calling the meeting to order a few minutes late, and also that our meeting is currently being broadcast live.
Thank you. And with that announcement, this is County Supervisor Joe Simitian. I want to thank you all for your patience this morning. Welcome you to our special meeting today by virtual teleconference of the county's Health and Hospital Committee. First item of business on our agenda is a roll call, and we will ask the clerk to please call the roll and establish the presence of a quorum.
Vice Chairperson Ellenberg.
Here.
Chairperson Simitian.
Here.
Thank you. You have a quorum.
Thank you very much. And the first item of business is our special hearing relating to the future and development of contact tracing operations in Santa Clara County. For members of the public who are visiting us for public comment opportunity, we do have public comment on the agenda, but just in order to manage our timing and be respectful to our panelists, we have that at the end of today's meeting. It is item number 3. We will get to it. And of course, we will also get to public comment on item number 2, but we'll do that public comment after we have taken the 2 panels. So we have a pair of panels this morning. The first panel consists of George Rutherford, Dr. George Rutherford, who is the Director of Prevention and Public Health and a Professor of Epidemiology and Biostatics at UC San Francisco School of Medicine. Dr. Rutherford, thank you for being with us. And we also have Dr. Laureen Nelson, a PhD, who is an Associate Professor of Epidemiology and Population Health at Stanford University's School of Medicine. We thank you for being with us as well, Dr. Nelson. We have then a second panel. And to somewhat oversimplify the structure of the hearing today, and I see Ms. Ellenberg leaning in, the first panel and the task we very much appreciate Dr. Rutherford and Dr. Nelson helping us with is essentially to background us, to ground us in some understanding and science of what contact tracing is, what it's about, why we do it, what value added does it provide. And then to have a second panel that is comprised largely of folks from our own county organization to talk about the practical logistics of standing up a contact tracing program in Santa Clara County in connection with COVID. So we're going to see if we can ask each of the panels to run no longer than an hour. I'm going to go to Dr. Rutherford and Dr. Nelson for some introductory remarks. They'll share with us whatever they think it would be helpful. And doctors, if you would just think of this as sort of contact tracing 101, both for members of the committee, but also for members of the public. And then once they've finished a presentation, we'll try and do about 10 minutes each, doctors. Then I'll have maybe 20 minutes worth of questions back and forth. We'll go to Supervisor Ellenberg. She'll have maybe 20 minutes worth of questions back and forth. We'll then go to our second panel, ask them to give an opening presentation. And again, probably 20 minutes from Supervisor Ellenberg with some back and forth and 20 minutes from me. We do all that right. The hearing will last about 2 hours. And the one thing I would just give a heads up to our county staff on is we did receive this morning at the last minute here what looks like some very helpful information about case investigation and some slides as well for a PowerPoint, I gather. I'm going to ask that you limit very significantly the use of these materials during the presentation. We discovered during our last special hearing on testing that we could get bogged down in the presentation if we weren't careful. So again, thank you for the information, but want to make sure we have time for the back and forth with the 2 members of the committee. So with all of that by way of preface, thank you, Dr. Rutherford, Dr. Nelson, both for being with us today. We're going to go to Dr. Rutherford first and say, Dr. Rutherford, what would you find it helpful for us to know and understand about contact tracing and its relevance, obviously, in a COVID-19 situation?
Yes, sir. Happy to help. And it's a pleasure to be virtually back in Santa Clara County again. I lived there for 5 years, and it's nice to be back. I'd also want to congratulate the county and the supervisors and the county executive and the county staff on doing such a solid job with controlling the COVID-19 epidemic. It's you really have led the way for the nation. I'm professor of epidemiology and a bunch of other stuff at the medical school at the University of California, San Francisco, and was the state health officer under Governor Wilson and the state epidemiologist under Governor Wilson as well. So I have some, and I've done this most of my career. Contact tracing has a deep history, and not to bore you too much. So if you're getting bored, let me know, and I'll amp it up. Contact tracing was first described in 1937 by the U.S. Surgeon General in a very melodramatically entitled book called Shadow Upon the Land. And the shadow was the shadow of syphilis, which was in the armed forces at that point in time and was cutting down on troop readiness. And Thomas Perrin, who was the Surgeon General, described a system of contact tracing to test, isolate, and quarantine contacts of military troops that had been diagnosed with syphilis, which at that point was a not very easily treatable disease. We continued to use contact tracing and still use it to this day for sexually transmitted diseases and HIV. Its use expanded in the 1950s to respiratory pathogens, mostly tuberculosis. But after after measles and rubella mumps vaccines became available in the late 1960s, it started to be used somewhat for control of vaccine preventable diseases. Specifically, much more recently, as we've moved into a phase of measles elimination. We do it for other diseases. I've been involved in doing it with Ebola virus and other things. As you can imagine, doing this for sexually transmitted diseases and for diseases transmitted by respiratory pathogens is kind of qualitatively a different series of questions one asks. And we have been doing, for COVID, I've been helping the San Francisco Department of Public Health for the last almost 2 months now stand up and get their, or I should say our contact tracing program for COVID up to speed. We're currently have about 140 people working on it. We've trained over 200. These are a combination of people from UC San Francisco who've been retasked for this job, county employees from San Francisco who've been retasked, and I will give specific shout outs to the city attorney's office, the assessor's office, and the librarians who've all been able to help with contact tracing. And then we've also used some of our own medical students and nursing students as clinical backup to the contact tracers. This is all a virtual process. So the way it works is that there's when someone gets diagnosed with COVID-19 and their results are reported to the county health department, which happens essentially instantaneously. Someone calls them up, whom we call a case investigator. We'll call that patient up, have a long interview with them about how they can isolate where they got infected, clinical issues. And then as part of that, we'll elicit contacts, people with whom they've been in close contact in the last X number of days. And the X number of days is the time it's 2 days before symptom onset. Almost all these people are symptomatic who are getting diagnosed. So if you became symptomatic today, we'd go back 2 days. If you became symptomatic yesterday, we'd go back 3 days. So that's the rough gist of it. Those names are then provided to people who are doing contact tracing, who will get in touch with them. We're talking all electronics here. We're not talking about knocking on doors. And then they will be advised to get tested. And depending on their test results, will either go into quarantine or isolation. And then on the back end of this, as people are in quarantine and isolation, there are a number of social services programs that are put in place to help them stay in quarantine and isolation. You can imagine a guy who's got a small family, a couple of kids, who is doing essentially day labor, who would have to go into isolation. Where does he go into isolation? San Francisco, we have hotel space set aside for these kinds of problems. But more to the point, where's the money going to come from? Who's going to buy the groceries? Who's going to make sure the wife and kids are okay? Those are the other sorts of things that we're able to help with. And that's a fairly sophisticated model, fairly advanced model. In addition, the California Department of Public Health has asked our group at UCSF to help train a statewide cadre of people to be contact investigators and contact tracers and case investigators we're now in the second month of that, on our way to training 10,000 people, sort of 3,000 at a time. These are all repurposed public employees and drawn from all over the state and are being reassigned, and the state is determining who goes where. So that's my contribution to contact tracing so far in San Francisco. It's working well. There are certain metrics that go with this. And I think we've been able to get about 70% of the named contacts contacted, tested, and dealt with appropriately. It's a lot more nuanced than that, but that gives you the 50,000 foot view.
Thank you. I very much appreciate it. Let me just ask Dr. Nelson what she would like to share as well, and then we will come back to both of our panelists with questions and conversation. But before I do go to you, Dr. Nelson, I just want to clarify one thing with Dr. Rutherford. Forgive me, you mentioned the number of contact tracers you are hoping to pull together and train in San Francisco. Could you share that number with us one more time, please?
So in San Francisco, we've trained about 250. Statewide, we've been asked to train 10,000.
I see.
And this
And in
is sitting in a room. This is all virtual.
Right. And in San Francisco, is there a number for the total number of contact tracing staff that you anticipate needing?
We're using it about 140 at our kind of current clip of new cases.
All right. Thank you very much.
That's about 40.
Dr. Nelson, thank you. Dr. Nelson.
Great.
Thank you. Welcome. And thank you again for joining us. Appreciate the help. Seriously.
Thank you. Well, I'm an epidemiologist, and my knowledge domain is more in the area of digital tools. And so I'm actually going to plan to show actually just one slide because this first slide, Dr. Rutherford already went over quite well. So I just wanted to give an overview of the types of contact tracing technologies that are out there. So it can be very confusing reading the news about Google and Apple and privacy experts' concerns and things. So there's sort of three main sort of areas of technology. One is based on a person's proximity. So it traces the proximity of pairs of people irrespective of where that proximity takes place. So the most common sort of technology used here is the Bluetooth signals from a person's cell phone are used in this paradigm. And so when people use this prospectively, they agree to download the app and then enable the Bluetooth capabilities of their phone to be used by the app in order to track them over time and share signals with other smartphones nearby, basically in order to track who they were in close contact with, so that when a person actually develops COVID-19, tests positive for SARS-CoV-2, then they can actually notify the app of that development, and then the people in the network that had been in close proximity, as detected by Bluetooth signals, would be notified if they met some sort of threshold with closeness and duration of contact in order to be notified that they could have been SARS-CoV-2 exposed. So this is the kind of technology that you've heard, that an unprecedented way that Google and Apple announced about a month and a half ago. They're collaborating on the technology to make this possible. They aren't actually developing an app. They aren't going to be actually tracking people. They are just changing their platforms so that Android phones and iPhones can talk to each other. And so that's a wonderful development. And without that, these sort of Bluetooth-enabled apps wouldn't be effective, or would be way less effective. So this type of approach has been successful in countries like Taiwan and Hong Kong and South Korea, and places where they can kind of mandate that their citizens use the app. It's less certain how effective they'll be in a free country like ours. Probably the most parallel example would be Singapore, where the Ministry of Health encouraged their citizens to use an app like this, and only 15% of people elected to use it because of privacy concerns. Actually, though, I think that app had some actual privacy concerns, whereas the apps developed now, and there's one that's developed at Stanford called COVID Watch, are completely privacy preserving. They don't share any personal information with anyone, and all the information remains on a person's phone. In order to be maximally successful, though, these apps need to be used by about 60% of the underlying population. So that's hard because only 80% of the population are smartphone users. And then, so if you, you would have to get 75% of those 80% to get to the 60% level. So I think the level of penetration that approach needs may not be sufficient. So I go next to the location-based digital tools. And so these are things that are either used prospectively by an individual that agrees to sort of sign on and use an app that will trace their GPS signals and their latitude and longitude coordinates over time. So that's one sort of location-based signal method. Another is a retrospective one, where a person that does develop COVID opts in to share their recent geolocation history just for the swath of time that's relevant to their period of presumed infectivity. And then there are some hybrid apps out there as well being used in North Dakota and Norway and other places. There's some really intrusive methods being used, such as the Healthy Together app in Utah that accesses phone contacts and Facebook friends. And that, although with a $3 million investment, has not been successful. Only about 13% of that population has downloaded that app, and it's kind of viewed to be a failure at this point. The last sort of set of tools is those that you're already very familiar with in terms of managing the efficiency of the digital case management. You guys have used Demaji. I guess you're now piloting Salesforce with respect to that. So I'll pause there, and I just wanted to say those few things.
President Simitian, you're
Oh, you're
currently
unmuted.
muted.
Thank you. Sorry for that. I was just asking Dr. Nelson if she could say a few more words about Demaji and Salesforce, because while our teams are using the technology, I doubt that Supervisor Ellenberg and I are using the technology, at least not to my knowledge at the moment. So if you wanted to lay out for us a little bit more how you see the utility, the functionality of those two technologies, I think that would be useful.
Actually, I'm less knowledgeable about that. Of course, Dr. Ho and Dr. Redmond would be able to speak to that. Just that I don't think it's collecting location history or anything like that. It's in a highly efficient way to manage the contact tracing process.
All right.
I understand.
Thank you.
Yeah.
Thank you. We'll go to the staff in the second panel on that when the time comes. Thank you both for the introduction, and we're going to use a low-tech way of seeing who responds, which is, if you will, simply raise your hand literally when I ask a question. And as I said, we'll spend about 20 minutes. And Supervisor Ellenberg, if you have a question or a follow-up that's on point, please feel free to just interject. I think we can make this a little bit conversational. And then we'll sort of turn the lead questioning over to Supervisor Ellenberg after I've raised a few topics. But again, my thanks, Dr. Rutherford, Dr. Nelson. I know everybody's incredibly busy right now. Appreciate you being here to help us through this. Let me ask a really basic question. Dr. Nelson at first, please, and then Dr. Rutherford. Dr. Nelson, you shared the technology with us in your commentary on the slides. Obviously, the long history of contact tracing and public health that Dr. Rutherford described, back in the day, those tools weren't available. There were other sort of more, I guess you'd call them almost shoe leather applications at the time. And I see a pencil being raised. What are the strengths and limitations of simply working on the phone and talking to people directly I'm gathering or guessing based on what I've already learned that just the challenge of people's imperfect memories is a big part of the challenge here. But could you flesh that out a little bit more for us?
Yeah, I guess you asked for me to answer first, and of course, Dr. Rutherford has very deep experience in this area. I would just say that adding technology to that process could potentially really help. If you had a COVID positive person's recent location history, it can be used to help them jog their memory of where they were and who was with them in those locations. So it could be used in advance of, say, a contact tracing interview to enable that process to go more quickly. I'll pause and let Dr. Rutherford. Yeah, go ahead.
Thank you. Dr. Rutherford, strengths and weaknesses of doing it old school, for lack of a better phrase?
Well, the strengths of doing it old school is we know what we're doing and we're not dealing with new technology. We use Demaji in San Francisco, and the state has chosen to use the Salesforce Accenture platform throughout the state. That's really just sort of people management, contact management, almost kind of like medical records, just keeping track of stuff. And it really doesn't have a geolocating function in it. But understand, a lot of this experience has been developed during the age of, during this era of sheltering in place. So people don't have that many contacts. Right now in San Francisco, we have 3.5 contacts per individual case that's been identified. We fully expect that to go up to 10 or so as people start to not shelter in place. So kind of keeping track of who's who and all these circles that keep wrapping back around, as you can imagine, becomes complicated. That's what this stuff really does a good job of, so you're not shuffling through decks of cards.
Excuse the interruption, doctor. When you say 3.5 or 10 contacts, that's over what period of time again, please?
It's the close contacts during the period of time that the index case is most infectious. So I'm going back to the start of March or mid-March when this got stood up in San Francisco.
But on each individual contact, is it how many contacts have you had in the last week, 2 weeks, month?
No, it's during the period of time that the case is infectious, which is from 2 days before symptom onset to the date they're interviewed and put into isolation, until somebody can put a mask on them, right? So this is the equivalent of giving them penicillin for syphilis. Right?
Thank you.
So we use the software for management purposes, and it works great. We also have a new app we're going to pilot. That's a kind of aide-memoire, which is to take it's exactly what Dr. Nelson's talking about, to help people to look at their phones and help jog their memory over where they've been in the last X number of days. We think we can get back 5 days without any kind of specialized software. But it's really only to help jog their memory, saying, oh yeah, I went to the Safeway here and I did this and I did that. So that will, I think, we're piloting it. How much more it helps people remember stuff, we don't know yet. It's on paper, it sounds like a good idea, but it's all with consent. It's done right in front of them. I don't know if you've heard these stories about South Korea, but if in South Korea, if you get reported, the equivalent of the FBI comes and takes your phone away off to their lab. They run it through. They find out where you've been. Then they run all your credit card records, and then they put you through all the facial recognition software. So, we don't see that flying too well in Berkeley, for instance, just as an example. So those are the kinds of privacy concerns that Dr. Nelson was talking about, just to give you an extreme example.
Thank you very much. Do either of you have additional comments you'd like to offer about the privacy implications of the technology? I noticed, Dr. Nelson, you were quite deliberate about both using the phrase and having it on the slide, privacy preserving. Thoughts that you can share? You may or may not know I have a long history in privacy protection, and so it's an area of particular concern to me, and I believe to many of my constituents as well, as we're looking at a relatively new set of applications as you've described. Dr. Nelson?
Right. Well, I think the groups with the most privacy preserving consciousness are those that are working on the Bluetooth enabled contact tracing. And the one here at Stanford, COVID Watch, and the others at MIT and Oxford are working on systems that will not in any way provide personally identifying information, even on the person's own phone. These are just electronic chirps. And so even if it was hacked, nobody would be able to make sense of it. So that is the beauty of the sort of privacy preserving Bluetooth enabled apps.
Thank
On
you.
the other side, the ones that do use GPS location data or the history, your geolocation history, are more concerning in terms of privacy, but those things are opt-in. So an individual could say, well, actually, I don't want to share my geolocation history with you, and that would be that.
Thank you. And presumably that, forgive me for leading the witness here, but presumably that requires an informed opt-in as opposed to a clueless opt-in, yes?
Yes, I should have said that. Yes,
No,
absolutely.
no. I just, I couldn't resist the opening you provided. So thank you for that, Dr. Nelson. Dr. Rutherford, other comments or observations about privacy implications of some of the technology that we're talking about?
Yeah, I mean, the real issue for me about the technology is what difference is it going to make? And then we can deal with the privacy issues. A lot of the people we see, and this is true of Alameda and Marin counties too, are people who are really real blue collar workers who many of whom live in multiple people in apartment houses and actually share cell phones among themselves. So we're not, everybody speaks Spanish, that's no big deal. But the whole business about, do you actually have a phone that we can contact that's yours individually, and do you have the right kind, and do you have all the right stuff on it? I mean, we see this as a big digital divide issue as well. So even before you get to the privacy concerns, which are numerous, there's the real question about, is anybody going to bother to do this? And Dr. Nelson said 15% in Singapore. I think there's a Washington Post poll that said 13% in the United States. So it's all out there in the land of gee whiz technology that's not going to necessarily be really applicable.
All right, thank you. Let me ask both of you, and again, feel free to just raise a hand or a pencil. Could you talk a little bit about testing and the importance of testing in order to identify the folks who are going to be subject to contact tracing? Your observations on that subject?
I can start.
Yes.
So in San Francisco, we have a great luxury, which is that the Chan Zuckerberg BioHub, with the consent of the donors, has repurposed large part of the lab as a CLIA certified clinical lab. CLIA is the licensing you need for clinical laboratory. And we've had a number of our own doctoral students, our graduate students, who are staffing it for free. So we have a lot of capacity for testing. Getting people tested that we identify as contacts has not been a big problem for us. And now it hasn't of the last, say, month and a half. And we do have capacity. In fact, we have so much capacity that the BioHub opened it up to other county health departments as well. So there's a recent outbreak in Marin in the Canal District of San Rafael, and they're running all the specimens for them. So having testing is obviously something you have to have in order to do this. We have not experienced that as a rate limiting step.
Thank you. Dr. Nelson, any comments, or should I go on to the next question?
No, George covered it well. So yes, next question.
Thank you. And staying on testing for just a moment, presumably the testing regimen needs to be robust in order to identify people who have had contacts. Yes, I mean, isn't testing the necessary precondition to having a contact tracing program?
Well, one could make a clinical diagnosis of COVID-19 disease, which has happened in some places. In China, they use clinical diagnoses. But it's mostly clinical it's mostly getting people tested that when they present with symptoms, that drives most of this. If we had large capacity, which I think we're all building to, we could get more asymptomatic people identified that way and have them, but why are they going to go get tested if they don't have any symptoms? One of the things that we've had success in doing, and I know Marin County's done this as well, is to set up sort of pop-up testing centers in geographical loci where there seem to be a lot of cases coming from, in order to try and identify people, as many people as possible with asymptomatic infection, and then doing the contact tracing off of them. That's a sort of different strategy but it's kind of part and parcel of the same thing, and it requires testing capacity, obviously.
Thank you. Dr. Nelson, any follow-up on that before I go on to the next question? Well, thank you. Let me ask both of you, I just want to make sure I use the term of art correctly. So I use the term of art isolation for someone who has been identified as having the virus, and quarantine for those who are folks who have been identified as contacts. Am I using the terminology correctly? Let me look to both of you here.
You would have passed your second year medical school examination. I asked that on every single test at the end of the year.
All right. Well, thank you. As I say, I'm still. Here's the question, and it's one I've raised with our own staff, but I'm appreciative of getting perspectives from other venues and other sets of experience, which is, our public health officers obviously have the ability to issue a formal legal order for isolation or quarantine, or to do some of this work, largely through persuasion, and hoped for cooperation. Any experience you can share about, how do people respond when you say, you've had hi, ma'am, sir, you've had a contact with someone who's been identified as having the virus, and now we need you to quarantine for 2 weeks, and with all that might entail. And Dr. Rutherford, you referred to some of the challenges, particularly for people of modest means. As this effort gets ramped up in our county and in the Bay Area, the state, and the nation, I'm just wondering how much pushback historically have we seen, or do you anticipate from people who say, the hell you will. I'm going to go about my business because, I spent 5 minutes with Dan a week ago, and I feel fine. So yeah, let's take it from there. Dr. Rutherford, and then Dr. Nelson.
You're a totally legitimate question, and I had to issue quarantine and isolation orders when I was the state health officer on more than one occasion. This actually seems to be working a lot better, and if we can find people, finding them is always the hardest part. We can find people. We find people to be very cooperative. But that is because Stanford, at least in San Francisco, there are programs that ease this period of time. There are places we can put people. There are places where we can house people temporarily. They're like hotels. There are programs for food and for income support. And the governor's made some of it, much of that available, but San Francisco's added to that. And so we actually get quite good cooperation. I mean, if we can get to people, they get that this is important, that they're at risk of spreading the disease within their own communities. And as long as we can sort of make it cost neutral for them, they've been willing to do it.
Dr. Nelson, thoughts?
No, actually, Dr. Rutherford's the expert in this area.
All right. Thank you. Then, Dr. Rutherford, earlier, if I heard you correctly, and please don't let me put words in your mouth that are not yours, but I took your comments to mean that to some extent the technology that you find most significant, most helpful is simply the database management of the large number of contacts who come through this process. Dr. Nelson, you're obviously looking at some of the more, I'll call it, emerging technologies. What, if I could go back to your slide perhaps on technologies, if we can pop that out without too much difficulty, I'm curious to know what your thinking is about what is the most promising or potentially useful tool among the suite of tools that's available.
Let's see. So do you see that share? You can see the slide?
We can. Thank you.
Great. Okay. Well, in some ways, it's hard to really identify which ones would be the best because they haven't really been tried. And to demonstrate, utility. I do really worry about the proximity-based notifications, in that, as Dr. Rutherford mentioned, there are individuals in our community that don't have smartphones at all, and those tend to be the elderly. Only about 70% or 60% of them have smartphones, and individuals of lower income also maybe around 60-70% have those. So the groups that are at the greatest risk for developing or to suffering from the adverse effects of COVID may not be covered by that method. The other methods are opt-in, and I think they could be very useful. I don't think we have any data yet on how many people are willing to use those methods. Although the Kaiser Family Foundation did a survey that said that 60% of people would be very open to using an app that was recommended by their public health department. And whereas, obviously if it were recommended by a technology company or quote government in general, they'd be less likely to do that. So I think public health departments in particular probably have a good connotation in people's minds, and they might be able to use these tools with greater utility. But we don't have any studies yet we can cite about how effective these are.
Got it. Dr. Nelson, this is a question of more than idle curiosity. What made you think this was an area you wanted to pursue as an academic and a professional? So I'm trying to tease out here a little bit. You're thinking about either the potential or concerns we should be thinking about as time passes. You obviously have decided that the technology side is an important sub portion. Forgive my lack of clarity here, but I think you understand what I'm trying to dig down on a little bit here.
Yes, I think it was after watching the proximity-based privacy-preserving Bluetooth sort of effort going forward, and knowing that such a high proportion of the population would need to be using it in order for it to be effective, I thought, are there other methods that could rely on informed consent, opt-in, that could take advantage of technology and still preserve people's privacy, and that the geolocation history would not be associated with any identifying information of the individual, for example, and so on. After they provided their sort of contact tracing, it could be removed, or it could be put into a database unlinked from their personal information to sort of map areas of potential hotspots that had occurred. So I thought that could have real utility, and our group is investigating that now, both for public health use, contact tracer use, as well as within Stanford University. They are grappling with how to monitor when the students come back and the employees come back, how to sort of monitor their potential exposures and mitigate them without trampling on their privacy. So just an area of exploration for me, realizing that the Bluetooth enabled capability, I'm skeptical as to whether it will work.
Well, this is a question for both of you, but starting with Dr. Nelson, and we can take the slide down if that's possible now.
Sure.
But Dr. Nelson.
Supervisor, I apologize for interrupting. I just want to keep us on time. We're at about 11:12, and I think we want this panel to end at about 11:30.
11:35 is my target. Thank you, ma'am. So, Dr. Nelson, obviously the technology has been extraordinarily helpful, in even in as simple a matter as setting up this virtual meeting. But I'm inferring to some extent that you're not altogether convinced, either of you, that the technology side is going to be the silver bullet, the magic ingredient, the secret sauce of getting this job done right now in the face of this particular pandemic. That it's important, that it's emerging, but that we may be looking at the next great public health crisis as the place where these tools get rolled out more significantly than in this case. Am I reading too much into what you both said? Let me start with you, Dr. Nelson, and then Dr. Rutherford, if you'd weigh in as well, please.
Yes, I think that is the case. Yeah, we just don't have the data to know. I think that none of these methods are mutually exclusive, that you could actually, like Governor Newsom has the chief technology officer from the Obama administration, Todd Park, advising about what app, if any, should be used in California. And so it remains to be seen, how effective that is, how many people will take that up, and what incremental sort of boost that might have. The other more retrospective methods, relying on location history, could also help a lot at the contact tracing stage, but we don't have data yet. So it's hard for me as a scientist to say anything about it because I like to make database decisions. So
that being said, is it, and again, please push back if I am mischaracterizing, but it sounds to me like what you're saying is, for the most part, it's still going to be the old school methods of public health and contact tracing. The technology will be helpful in making sure we can keep track of the very significant number of folks that will be contacted through such an effort, but that the emerging technologies will be, one or two or three more tools that we can use on the margin to perhaps improve performance, but that the basics are still going to be sort of central as this particular effort goes forward. Is that a reasonably accurate summary?
I think so. Until we have data otherwise, I think that is probably the case. And I'd love to hear from Dr. Rutherford about the tool that he has decided to use in conjunction with contact tracing.
Dr. Rutherford?
Yes. Yeah, I think you hit it right on the head. I think this is, with all due respect to the IT industry, I probably have been contacted by 1,500 different people who want to show me their apps. We got to move forward with this. And while I'm completely open to the idea that that something might really work, I think that, right now with the system we have is working, and I want to make sure we can get it up and running. And then if we can improve it, great, let's improve it. But, within the constraints of the privacy laws we have in this country, in the state, and within the constraints of people actually being able to use it and for it to be truly practical.
Thank you. One last question, then I'm going to turn to Supervisor Ellenberg, and for either Dr. Rutherford or Dr. Nelson or both. That I noticed the term close contact or significant contact is been used, and I gather that it is to some degree a term of art. What does that mean, and why is it an important distinction?
In the days before people started to wear masks, like in the house, you had to be, the models would suggest that you need to be in contact with somebody for 10 minutes or more within 6 feet. And that's that increases your risk of having been infected. Now that people are wearing masks and people are outside, there's some other considerations that come in. But you don't want to be sending people just because they saw somebody across the cantaloupe aisle at Safeway off to get tested with the understanding that if they test negative, they have to go into quarantine for 2 weeks. That's not, you have to get this right at the beginning to understand how close the contact was and how long they were in contact with each other, and the other mitigating features like were they inside or outside? Did they somebody who had a mask on? Did they, blah, blah, all those kinds of pieces have to fit together in order to say, okay, I'm really worried about you, that you really, there's a high likelihood that you got infected. Go get tested. And if you test negative, we want you to go into quarantine. And the reason we want you to go into quarantine is because we think there's a high likelihood that you're going to become infectious in this period of time.
Thank you.
And congratulations
Dr. Nelson.
on getting the terms right, by the way. That's stupendous.
Thank you. Dr. Nelson, anything else on that one?
I guess I would just say that in India, I've heard and have through a good source that they are using a digital tool to be able to sort of rank order people in terms of the probability of being infected. And the people that they rank at the highest tier the actual infection prevalence has been around 50%. Those that are they're not at the highest tier, it's down around 8% or something. So there could be a real utility to using these apps if they are able to achieve that kind of triage, and where the infection rate is much higher in a group that could be pursued much more vigorously and rapidly. Yes.
Thank you. Let me turn now to Supervisor Ellenberg, who will have questions and comments as well.
Thank you. And I'm going to set my timer here for 20 minutes. I want to be very respectful of everybody's time. I know that our panelists, second panel is waiting, expecting to start at 11:30. It's going to be about 10 minutes after that. And thank you both, Dr. Nelson and Dr. Rutherford, for the really useful information this morning. Can you share a little bit about emerging best practices for large-scale contact tracing across the U.S. Or abroad that might have applicability in the Bay Area? And who's doing this really well right now?
You are. I mean, we're doing it well in the Bay Area, frankly, and everybody's looking to us about how to do it. I get contacted daily by other states who want all our stuff and all our training materials. So that's one answer. The real answer is Australia and New Zealand, where they've been able to, where they had a limited number of introductions and were able to introduce a very aggressive system of contact tracing, which might or might not pass muster here, and really have been able to stop new infections. And in fact, they've reopened their borders, but just to each other. New Zealand has this very cool system where people are issued essentially a credit card, like a smart card that you carry around with you. And it's all anonymized. And they can tell if somebody, if you as a person who has card number X turn positive, they can go back and look at which other cards you've been in contact with for an extended period of time that would meet a criteria. And then you have to talk to everybody, obviously. But they're the ones that have been some of the most aggressive and some of the best, but they're dealing with very small numbers.
Right. And as a follow-up, I'm glad to hear that we are in that top tier.
Yeah.
But can you tell me what some other Bay Area counties or around the state or nation are doing to scale up their tracing workforce? Are they using existing staff, community volunteers, students, and just generally, what's the landscape, and what factors do you think our county should be considering to build our staff?
So if I may, Dr. Nelson, we've been asked by the state to train 10,000 people, probably more like 20,000 when they get through checking off all the order boxes, of people who are repurposed civil servants. So they're already public employees, they're already employed, and they need to have the training to become contact tracers or case investigators. I did a small group for one of our sessions last week and had people from Placer, Monterey, Sonoma, and Fresno counties in it who are all kind of in health. One was an EMT, and one was a public health nurse, but they hadn't ever done any of this stuff before. So, that's the kind of person they're trying to start with, at least here in California. We also have a ton of interest from the state college system, from community health centers, from the UCs, and from Stanford about training students to do contact tracing. Now, you guys don't have a UC campus in your bailiwick in Santa Clara, but the UC campuses it's kind of like dealing with VA hospitals. It's separate from county government. The counties really don't have oversight. So this was kind of me being slightly passive aggressive, saying, you guys want to call up 4 times a day and tell me how great their UC students will be. Why don't you do your own contact tracing, right? When everybody goes back to school. And so we're going to train them as well. I think the places that have stood up large contact tracing forces like Los Angeles have primarily used retasked public servants. And augmented as needed with some volunteers, especially medical volunteers.
Do you know, this might be too in the weeds for outside of the UC system, but do you know if students will be given academic credits for this work?
We give our fourth year medical students academic credits.
Excellent.
Which means they
You
pay us to
mentioned
do it, right?
that the volunteers are primarily people who are in the medical field. What do you think of just a general wide cast volunteer net? Have you seen that be successful in any, to scale in any way?
I'm not, we get a lot of volunteers, and we have a long list of volunteers. We sent over our list of volunteers from Santa Clara County to the health department earlier this week. At least we were supposed to. I don't know if it's gotten there yet. And I think it's fine, especially people who have prior professional training. But we also get high school students who want to do this, and lots of college students. You get into having to vet a lot of people, and get background checks and stuff like that before you can start passing out millions of phone numbers to people. But it's we've trained volunteers. We just aren't needing to use those who don't have specific medical training yet. I think it can work.
It's very intensive work just to vet the volunteers. I imagine you need a large vetting staff to do that in real time to some degree.
Yeah, that's the virtue of using our own students and our own retask public servants and people from UCSF. They've already been vetted.
Sure.
Right? So we're using retirees too who've already been vetted. So, but
we don't have UCs, but we have San Jose State and Santa Clara University and some very fine community colleges. And I think that is a good partnership. I appreciate that.
May I, Supervisor, may I? So
please.
I've been really convinced that the Cal State system is the ones to do this rather than UC. And they typically have public health majors on their campuses. And we've been working with a guy who was the emeritus head of public health at Northridge to set up a curriculum that would help train people to do this work. Because at some point in time, all the retasked public servants are going to have to go back to what their real jobs are. And then the question is, where's the workforce going to come from? You want it as close to the grassroots as possible. So that means community colleges first, and the Cal State second, and then doctoral students in philology at Berkeley probably third on the list about who's going to be able to talk to people and get them to do things that they don't necessarily want to do.
Right. Thank you. I really appreciate that, and I would think that academic credit would go a long way to encouraging students to do this.
Supervisor Ellenberg?
Yes, please.
Could I say just a few things?
Of course.
Don't leave Stanford out. Actually, my doctoral student in epidemiology is being trained this week as a contact tracer for Santa Clara County, and I think that your recommendation to have associated credit is a good one. Certainly would offer that to her. She just had to clear it with me so that when she was making slower progress on her dissertation, I would understand why. And of course, I was fully supportive. And in terms of other states, the other things like Washington State they've got a 1,500 person workforce, including 500 from the National Guard, which is being used in several states, National Guard. Missouri is actually working with colleges and universities primarily. Massachusetts is working with nonprofit health organization Partners in Health, and they actually they budgeted $44 million to hire 1,000 people. So some states are hiring and some states are getting volunteers.
Are the community-based organizations that you're referencing, are they doing the contact tracing, or is their focus on the isolation supports?
I don't know that level of detail. I'm sorry.
That's all right. Thank you.
Find a link, send it to you.
But that will actually lead into my next question then about isolation and quarantine support. What are some best practices? Who should we be looking to there as models? Dr. Rutherford, you referenced some resources in San Francisco to supplement state resources. Is income replacement being implemented anywhere for cases and contacts?
So in San Francisco, there's a statewide program for income replacement. So the federal level, there's unemployment. Okay. At the second level in California, there's an income replacement program that the governor's put through. And that's been supplemented in San Francisco. So you don't have to be a citizen. You don't have to be paying taxes, all those kinds of things in order to get income replacement. Income replacement's a big deal, especially for people who are essentially getting by as day laborers. And then the other things, where are you going to be? Physical location, food, who's going to help your family out while you're gone. All those kinds of things are hugely important. And there's a service in San Francisco called the Isolation and Quarantine Service that is doing this. It largely uses public health nurses and social work and people from social work. It's being reorganized now. Apparently, I've been told that we're going to have sort of more responsibility for it. So I come back in a month and I can answer your questions directly. But that stuff is big, and I think different places are doing it differently. That is a model of how to do that.
Yeah, my sense is, being very much new to all of this, is that our CVOs that are in the neighborhoods, that have the relationships and the culturally specific connections, are really ideal partners to be doing that. So it's interesting that San Francisco is focusing more on its current county staff.
Well, they're paid for already.
Sure.
That's the bargain part of this. So.
Thank you. Do you want to add anything to that, Dr. Nelson?
No.
So moving on then, what do you think are the most critical legal and policy issues that we should be considering as we scale this contact tracing work and ensuring that it's really effective?
May I add a scientific issue, sort of an open scientific issue as well?
Of course.
In something like syphilis contact tracing, not to keep coming back to sexually transmitted diseases, there are people who are at higher priority for contact tracing. So people who have more partners, you can imagine, right? So what we're trying to work out is who's at the highest risk of transmitting. As you may know, there's this phenomenon of super spreading, that people who infect many more people than a sort of another person would. And we think that may be due to the higher viral loads, the greater number of viral particles per whatever volume you want in their noses and in the backs of their throats. We can actually measure that through, and we can approximate it as we do the polymerase chain reactions, the so-called PCRs. The greater the number of times you have to run the specimen through the machine, which are called cycle times, the lower the concentration was to start with. So if somebody turns positive at a very low cycle time, that means they have a very high viral load. We would prioritize those people. We have not started to do this yet. This is kind of an open question right now. A second thing is that we think occupationally, some people are at exceptionally high risk of spreading the disease. This is the equivalent of kind of sex workers with syphilis, right? And in this case, they're people who work at multiple long-term care facilities as staff. Those are people with whom we're exceptionally concerned. And so there are probably a few other things that we could put on that list, but those are the ones that concern us a lot. People who have high viral load and people who are going to come into contact with lots of frail people. Yeah.
You're specifying working at multiple long-term care facilities. That might be some.
Yeah, I mean, if there's a Laguna Honda with 750 beds, yeah, they would go right at the top of our list as well. It's a surprisingly large number of people who work in long-term care, who work at multiple facilities.
So I wonder, as a first sort of harm reduction piece, if that's something that we can work with, and I need to give that some thought, but it's an interesting issue if we can limit people to be able financially to work at just one. That would be considerably helpful. I'm sorry?
Or just make them the highest priority for testing. You test them weekly, for instance.
I test doing. And are there any other safety protocols or protections that you would recommend that are put in place?
Well, we tested, there's all this question about visitors in long-term care facilities. That was sort of the first thing to go. And that's been socially very, very, very tough, as you can imagine.
Sure.
And also in the acute care hospitals, people are saying, no, I don't think I'll get that liver transplant just yet, because I don't want to be in a place where nobody can come visit me for, X number of months. So those are, this whole business about visitors is another control point. We've also test residents of long-term care facilities, especially when a case turns up. We'll do kind of cluster investigations around them. But in San Francisco, we're trying to test all the people who work at long-term care facilities every 2 weeks. And I know you guys are doing something similar where whether you're really at the 2 weeks yet or not, I'm not sure, but that's an important thing to do as well. The only other real control on long-term care facilities is about people who are coming and going and trying to keep that to a minimum.
Yeah, that really is a critical social and mental health piece, though, too. I hope that we can come up with some acceptable mitigations that will allow even, limited visitors in a specific area with whatever equipment is needed. That really is an important piece. I think I have just one or two more questions, and specifically, again, sort of building more on the long-term care facilities, other congregate settings, hospitals, jails. What modified strategies or tools to support contact tracing should be considered for those types of institutions? We've had good success limiting the spread in those settings here in this county, but it certainly will be an ongoing challenge, and would be glad for any feedback about how we might continue improving. Either.
Dr. Rutherford probably has more experience in this area.
I hate to do all the talking here. I'm sorry.
We love it. We love it.
We screen. The simple thing is to screen everybody coming in the door. But which is more easily said than done in the setting of jails. I can tell you in San Francisco, at least in the old days, the average length of stay in a jail is 6 hours, because it's all the DUIs that are getting turned around and stuff. So it's not, you have to be there for a little while for this to actually be meaningful. The other screening people on entry to long-term care is pretty straightforward. It becomes complicated with homeless shelters, right? Because people come and go and come and go and come and go. You could have, we've had homeless shelter outbreaks. It's still a work in progress. I don't really have a great answer for you yet, but frequent testing is key. And as you find cases, they spread like wildfire through the shelters, and you have to be really careful about who's in, who's not in. Can they come and go in the middle of the day? You might even have to segregate them off into more of an isolation facility, some for quarantine, some for people who are free and clear.
Thank you. Dr. Nelson, any last comments, anything that we missed that you want to make sure we know in these last couple of minutes?
No, I don't think so. It's been great.
All right, then turning it back to you, Supervisor, and looking forward to the next panel. Thank you.
Thank you both, Dr. Nelson and Dr. Rutherford. And I think the only thing I would say is Supervisor Ellenberg and I probably both wish we were getting academic credit for being with you this morning. But
you can get academic credit at Stanford. You can get academic credit at Stanford. The only thing separating you from that's about $500 per unit. So.
There you go.
How about an honorary degree in epidemiology for?
There you go. Thank you.
That we may earn. Thank you so much.
In all seriousness, thank you to you both for your work and for sharing your wisdom today. Really much appreciated and very helpful as we make our way through these next steps. That being said, that does take us to our second panel. And we have a slight update here. Supervisor Ellenberg, I'm very pleased to be able to say that in addition to participation from Dr. Evelyn Ho, who is our health program specialist at the Public Health Department, and Douglas Press from the County Counsel's Office, Sarah Rudman, Dr. Sarah Rudman, also from the Public Health Office. We have a couple of folks from Haluna Health. You will recall, Supervisor, I know that we just recently approved a contract with Haluna to help us with our contact tracing efforts. So I want to say thank you to Peter Dale, who is going to raise his hand and let us identify him. And also, we have Tim Seifert, and I hope I am pronouncing that name correctly. Thank you, Mr. Seifert. We did get some late-breaking materials from our county staff, and in order to make sure that everyone who has something to share has a chance to share it, I'm going to ask the folks who sent us the materials to be very brief in their presentation. And by very brief, I mean 5 to 7 minutes max, please, so that we do have, again, 20 minutes for questions, with Supervisor Ellenberg taking the first 20-minute increment, and then I'll take a closing 20-minute increment. So if we can spend about 20 minutes hearing from the very talented, knowledgeable group we've got assembled here, then go to the 2 supervisors, that would be helpful. Let me just ask Evelyn Ho, excuse me, would you like to lead us off?
Good morning, supervisors and the committee. We're glad to be with you today. I'm going to share my screen. Give me 1 second. That comes through. I have Dr. Rudman, Assistant Health Officer, with me today, and we're pleased to have Peter Dale and Tim Seifert from Haluna Health joining us as well. So I'm going to hand it over to Dr. Rudman, who will kick us off today.
Thank you. And with that fabulous overview from Dr. Rutherford and Dr. Nelson, I'll really focus on the Santa Clara County specifics of contact tracing here, and we talk about our operations, and then leave room again to focus on your questions at the end of the presentation. So in the context of how case investigation and contact tracing works in general, Santa Clara County's data that allow us to do this come first from electronic reports received from laboratories who have tested a Santa Clara County resident to be positive, and from healthcare providers who have identified a positive case, either clinically or from a lab result, reporting into a statewide system called CalReady, that now, because we have changed into the state's Salesforce platform, which has been renamed Cal Connected, we're able to receive an electronic stream of those data into the Cal Connected system. And because this is a web-based system, all of our contact tracers and case investigators are able to operate remotely in that web-based system to see these cases who've been identified as Santa Clara County residents ill with COVID, and be able to provide that detailed case investigation, elicit the names of people they've been in close contact with, document that information, and then reach out to those close contacts. The types of questions we ask in the context of that case investigation are exactly as Dr. Rutherford laid out, using memory aids to help people understand who they may have come into close contact with, and document those names. We also take as much time as the patient needs to answer their healthcare questions and make sure we're directing them to any clinical care they need. And then in fairly great detail, we assess their personal needs by starting out simply with, what do you need to be able to safely stay at home away from anyone else you might expose during the period where you could remain contagious? We ask everything from, do you have access to food? Do you need help with grocery delivery? Do you have access to your medications? Do you need someone to pick them up or help have them delivered? Will you need assistance with transportation to doctor's visits? And then most importantly, do you have a home, and is your home a safe place for you to be, both in terms of you staying there while ill and in terms of other people who may be in the home? And while I really like Dr. Rutherford's description of San Francisco's isolation and quarantine group, we've had something similar to this built up in the county that covers that same need for our cases and contacts, and in addition, proactively identifies other unstably housed people who have not yet been exposed but who are at very high risk, and helps to house those individuals as well. And if needed, we can talk more about the details of those programs. And then once we've elicited the names of contacts, we move on to reaching out to those contacts, making sure they're aware that they've been exposed, although doing so while describing the minimum amount of information we need to disclose in order for them to understand that they've been exposed. Similarly, assessing their ability to safely stay home for the 14 days we recommend they stay away from others after their exposure, assuming they remain negative. And similarly, making sure they have whatever they need to safely stay at home. I think it's also important to point out the things we don't ask, and the state of California has been helpful at messaging this, as well as our public information officers. We make it very clear to people that we're never going to ask their social security number, their documentation status, or any financial information. We also provide abilities for them to validate the call and make sure that we can prove it really is the public health department or our proxies calling on our behalf, just to provide them information they need to stay safe and healthy. And so what we're asking people to do in some of our public messaging is make sure that people answer the call when we reach out to them, so that they know why we're calling, know why we're not calling, and that we're doing everything we can to protect their privacy and information. And so that we can effectively transmit this information about how they need to stay home and what they need to do to keep from exposing others in order to stay ahead of chains of transmission. From there, I'll pass things off to Evelyn to tell you more about the details of our workforce who's going to do this.
Thank you, Dr. Redmond. So as previously reported on Tuesday at the Board of Supervisors meeting, we have an aggressive growth plan to grow our team to potentially a 1,000-person workforce. We are anticipating this looking at the projected potential number of cases and the number of associated contacts. So as cases numbers increase with easing of restrictions, the number of contacts that each person will have, as Dr. Rutherford stated earlier, will also increase. We have seen similarly in Santa Clara County, our average number of contacts per case currently is about 4 contacts per case. But as more individuals return to work and are participating in other activities outside of the home, that number of close contacts will increase over time. So our numbers, projected numbers, are aggressive so that we can stay ahead of this transmission of COVID within the community. By next Monday, we will have 180 individuals who have been identified and trained and live doing this work. As of today, we currently have 96 who have been deployed. This is a combination of county workers and community volunteers. Our workforce sources are a combination of county employees who have been identified to be reassigned. There have been 301 of them. They have been tasked, some of them have already been deployed, and the remaining 220 have assignment dates to begin training starting next Monday. That will occur over the next 3 weeks. In addition, we have a request to the state, as Dr. Rutherford talked about, training the large workforce of state employees that are going to be reassigned, could be reassigned to this work. We have requested 500 individuals, which is proportional to the 10,000 initially they were estimating. And finally, we have 962 volunteers who have completed multi-step registration and vetting to serve as county disaster service workers in this effort. These individuals have committed and stated that they are available for a minimum of 32 hours a week and can make a 6-month commitment. And so we right now feel confident that we are able to continue to scale. We will continue to scale slowly over time with 100, 150. That's actually a significant increase in the workforce, but we do not need to bring all 1,000 individuals on board today. For example, as of today, we only have 19 new cases identified. And so we want to ensure that we're using everyone's time that they're providing for this effort as efficiently as possible as well. So we will roll out the scaling over time. As for the strategies we are undertaking to ensure and build the stable workforce, knowing that we will need this workforce likely for up to a year or longer, we are working, as I stated, to identify all available public employees. We're working on partnerships, academic partnerships, for example, as previously described, to provide a stable volunteer workforce. We have reached out, we actually have a partnership with Stanford, for example, who a faculty member there who normally leads a service learning course that deploys up to 200, 250 students to work in their free clinics that are currently not operating. So these are students who are committed to 20 hours of service regularly anyways, have a deep commitment to underserved communities, and are already learning about health coaching, health education, motivational interviewing. They're adapting, the faculty at Stanford are adapting and developing a new course to meet the case investigation and contact tracing efforts. And students will receive course credit for making a 2-quarter commitment to this work. Similar models exist for San Jose State and Santa Clara University as well, and we are continuing to finalize those partnerships. We are also working with Haluna Health to select 95 temporary contracted workers that will provide stability to the team over the next year. We are focusing much of this workforce on ensuring that they are individuals who know our local communities, especially communities that have experienced disproportional impact of COVID-19, to ensure that as we are making these calls, we are able to build that trust, have the cultural understanding and humility and the language skills to be able to work in partnership with these community members to make sure that their needs are met. And finally, we are working on additional strategic partnerships to address workforce supply, funding, and sustainability, working with corporations, CBOs, and others. And internally, we are actively working to develop a sustainable infrastructure for recruitment, prioritization, engagement, and vetting in partnership with Haluna. And I will skip this next slide, but it describes our training, the extensive training that is provided, and we're constantly looking and revising from lessons learned to ensure that all team members of this very large and diverse workforce are sufficiently equipped to do this work. Team leads have been assigned to each group of 10 tracers, and they will continue to monitor and provide additional supports of workflow changes, guidance. Additional training is provided as needed as well to support this workforce that is providing their time to do this important work. And I'm going to turn it over now I'll leave the slides up. I'll turn it over to Peter Dale and Tim Seifert from Haluna.
All right, thank you, Evelyn. And thank you, Dr. Udman, and everyone on the call today or Zoom. I'm Peter Dale. I'm the Chief Program Officer for Haluna Health, and I'm also joined by Mr. Tim Seifert, who's our Chief Human Resource Officer for Haluna Health. I have a couple slides I just wanted to go through. The first slide is just an overview of Haluna Health, so you know who we are as a nonprofit. And as part of that slide, Haluna Health's been around for over 50 years. We are public health mission driven, meaning we are a nonprofit, but we primarily focus on public health initiatives, which is very broad and includes a lot of different types of topic areas. We've been around since 1969. We've had, we provide program and support services to academic researchers, public-private consortia, local public health departments. We are actually, our nonprofit was actually born out of Los Angeles Public Health Department, for their need to open and find a way to manage the WIC services for all of LA County. So we currently still run that WIC program, and it is the largest WIC program in the nation, funded by USDA, and which runs through the California Department of Public Health. We help out develop and implement population health programs. We customize and approaches for social innovation, which help address the unique needs of the communities that we serve across California and in other states. Just to give you a snapshot of other types of areas that we are in chronic disease, community health, disease outbreak investigation. We are heavily involved with the CDPH, Richmond Labs. We are part of a partnership as agent for the Epidemiology Laboratory Capacity Grant, which is with the CDC, which is really involved with all of the surveillance, contact tracing, and so forth that are going across states, as well as funding coming from those the CDC. We're also part of education, HIV research and prevention. In San Francisco Department of Public Health, we are heavily involved with their work in public health, as well as homeless initiatives, street outreach to actual temporary and permanent housing for the homeless, and supportive services. Maternal and child health, overdose prevention. We do research with the San Francisco Department of Public Health, as well as tobacco cessation and substance abuse type programs. Our core services include grant management, project management, HR management, fiscal sponsorship, and accounting support. We also do direct programs as well as assist, because we are a nonprofit. A lot of our programs choose to open an agency fund where we can help them fundraise to provide more funding and expansive areas for them to provide service to the communities. Overall scope, as part of this contract with Santa Clara County, is for us to act as a consultant and support services for the design and implementation of the staffing infrastructure that's required as described as Evelyn in the previous slides. And that includes volunteers, DSWs, as well as a small cadre of folks that will be actual paid employees. And this will help with the case investigation and the contact tracing moving forward for the CICT program. We go out and we identify and train the cohort of volunteers, which we currently were doing weekly cohorts for the county, and we help with the training, the human resources, the oversight of the volunteers, the management, ensuring they're getting through their training, assessing their training, their completion, as well as working with Santa Clara County as the lead, and we're following their guidance, their cadence, and working through all of the volunteers and the schedules, as well as the disaster service workers as leads. And so we are working together as a team. We follow Santa Clara County, and we're there to support, to really stand up this infrastructure as described by Evelyn, to the goal of 1,000, to really take on the contact tracing efforts, as well as work through the various phases that have been part of this implementation within the scope, from training, tracing, the cadence, the communication to volunteers, to a variety of onboarding, as well as ensuring that they're meeting the criteria, as well as adjustments as we're bringing on and going live with the various cohorts weekly. And I just wanted to end and say, we really appreciate this partnership. We are excited about this partnership. I think that Santa Clara County is ahead of most counties in regards to the state, and we're very glad to be assisting you with your infrastructure needs.
Thank you very
Evelyn,
much.
that ends our comments.
Thank you. And let me just ask Mr. Press from County Counsel's office before I go to Supervisor Ellenberg. Anything you want to share in terms of legal issues we should be aware of as all of these folks go about their work in the weeks and months ahead?
Well, I just wanted to provide a little bit of background about some of the legal foundation. Quite frankly, I don't think that the legal foundation and support for isolation, quarantine, and contact tracing, it's pretty well established. And so I can walk you through a little bit of that during my presentation, but I also wanted to talk about some recent changes in federal and state law to better support people in isolation and quarantine. But other than those two topics, I don't have anything to add at this point.
All right. Why don't we see if we can fold those into some of the questions that are coming. And Mr. Seifert, forgive the mispronunciation of your name earlier, but anything else to add briefly to Mr. Dale's comments, or are you here to provide backup?
Mainly backup, and no problem with the mispronunciation. So it happens all the time.
Thank you. I'll go to Supervisor Ellenberg then. Thank you. I'll go to Supervisor Ellenberg then and ask her to take the lead on this next round of comment and question.
Thank you so much. My questions are very wide ranging, so bear with me as we try to cover a lot of ground in 20 minutes. First, I think directing to Evelyn and possibly Dr. Rudman, just basics. What are the days and hours that the tracing team will be working? And is the isolation support team on the same schedule?
Thank you for the question. Currently, our operation is 7 days a week, 8 a.m. to 5 p.m., and we are exploring adding additional hours as people return to work more, knowing that we may need to reach people outside of typical business hours, so extending those calls into the evening. Currently, we're a 7 day a week operation, 8 to 5.
And the isolation support?
I can add that I don't have the details of their full hours. They do have some availability as late as 10 p.m. And we have emergency protocols in place for urgent housing needs that may occur overnight.
Thanks. The ledge file indicates that contacts will be encouraged to go to their primary care provider for a test, or will be provided with information on community testing sites or a warm handoff to Valley Connect. How does the tracing team then assure that the contacts actually get tested and as quickly as possible? And how are those results integrated back into the investigation?
Sure. So as the state continues to build the system in Salesforce, Cal Connected, that it will eventually capture those data automatically to be able to help us measure exactly how many people follow our recommended testing first as soon as they're aware that they're exposed, and then again towards the end of their quarantine to make sure that they are really have made it through their quarantine period without becoming ill. Right now, while those data are not automatically integrated, we have a number of ways to keep an eye on that. We are working on a system where we would follow back up later on in the quarantine period, but again, that's not fully built out right now. In the meantime, we also monitor negative test results that are coming into the CalReady system. We do the warm handoff, and then we work really closely with a separate testing capacity group built out of the Emergency Operations Center that is monitoring testing capacity across the county, both in the areas that the county supports, such as Valley Medical Center's testing capacity or other pop-up community testing. We've supported additional community locations like Verily or OptumServe, and then finally, all of our other healthcare providers in the county. And that group, whenever they're aware of a mismatch of testing capacity and the patients we know need it because they've been exposed, we work together to reach out to those healthcare systems and see what they need in order to increase their capacity and understand how to be able to comply with the recommendations we've put out about ensuring that exposed persons are able to be tested.
Thank you. That's good. And I appreciate it. Sounds like there's a prioritization system that's in place with the private providers who often have more limited capacity for testing. Oh, I just lost my thread. Hold on. Oh, the other part of the question was, can we do anything beyond recommend that they get testing? Are we forcing isolation? Is there a mandate? Something in place that they have to get tested, or these are strongly encouraged suggestions?
Well, thank you for the question, Supervisor. And I know Chairman Simidian has asked a similar question previously. I think we approach that concern from both the carrot and the stick, both figuring out what people need in order to comply with the isolation and quarantine, and then figuring out if there are rare situations where it's appropriate to compel specific follow-up or infection prevention guidance. Mm-hmm. What we find when I'm sitting on the floor with the contact tracers, reaching out to individuals, is that the vast majority of people really do want to protect their community, protect their family members, protect their own health, and seek the health care we recommend and comply with the quarantine and isolation instructions. And the few times that people don't, it is usually for very good reason. It's usually because folks have a reasonable fear of losing their jobs, being unable to pay rent, being unable to care for people. And that's exactly why our isolation and quarantine support systems are so important and so aggressively built out to be able to meet those needs. In addition, where it's absolutely necessary, we do have the option of issuing isolation and quarantine orders. We do have the option of contacting an employer to let them know they have an employee who is not safe to allow into the office or the healthcare facility right now. But we find that it's very rare that we have to use any of those means because the vast majority of people are really trying to protect those around them.
Thank you. I might circle back to that with some more questions about the isolation and quarantine supports, but I want to focus first on the workforce scaling. What can you tell me about the mechanism that's being used to identify county employees with the relevant skill set for this work?
Sure, I will take that. This is Evelyn. So we reached out to working with our Employee Services Agency and then with department heads. First, it was to identify individuals who were on paid administrative leave and in good standing who could be redirected and assigned to this work. And then additionally, based on the skills and requirements that we were looking at, we looked at specific job codes that would match well with the contact tracing efforts. So codes such as office specialist because of the attention to detail and data entry, health services representatives. So we worked a long list of potential codes that match with the skill set that we were looking for. Finally, we also recognize that there are employees who may have skills beyond their existing job codes. So we asked department heads to also identify additional workers who they know, because of personal relationships and professional relationships with them, may possess additional skills that could be of service in this effort. To that end, we requested that they identify as many individuals as possible within their departments who could be reassigned to this work.
Thanks. And the ledge file made a general reference to discussions with our CBOs. I'm a little bit concerned that we haven't solidified partnerships with either cities or with CBOs to date, at least as far as I know. Can you give me a status update on the engagement with our CBO partners and other cities on contributing staff to these efforts?
Sure. Related to cities, we have issued an initial request for city workers. We recognized at that time the request included a fairly long engagement and a fairly extensive amount of time. Since then, we have continued to work with cities and communicating to see if there are workers who could commit for a shorter amount of time that could be reassigned. So those conversations continue to be underway and are being handled by the County Executive's Office. In addition, the County Executive's Office, and I don't know if Miguel and Jeff would like to speak to this, have also been in conversations with some of the CBOs about additional partnerships there. In addition, though, we have talked to other CBOs that the Public Health Department works with, really around the deploying of volunteers, how CBOs could help us in the recruitment of volunteers, but that's through the public health partnerships there.
Thank you. I am aware that the conversations are happening. I'm just hoping for an efficient timeline on the conversation so that we really can stand up all of the supports that we need, which will lead me back to the isolation and quarantine support questions. It was reported that screening for isolation supports is done by the tracers. Can you talk a little bit about how that process works to refer residents to the support team and actually link them to needed resources?
This is Sarah Redmond. I'll speak to the first piece. So the conversation at the level of the tracers with either the cases who have the disease or the contacts who've been exposed goes into a great amount of detail about what someone's home and living situation is, so that we understand what supports they may need. At that time, the tracers are instructed to involve their team leads. There are also clinical supports for each tracer if there are further expertise needed to understand the needs, and then a centralized phone number for referral to meet the broad number of these needs. I'll see if, Evelyn, do you have anything you want to add?
So we work closely with the isolation supports and human services supports group that's operated out of the Emergency Operations Center currently, in close coordination with them to connect them to additional resources through that hotline and the warm handoff and direct handoff that we can have with them.
For isolation supports like housing, rental assistance, and other resource-intensive supports, is there any kind of verification of need required of the cases or contacts?
So there are additional assessments that are provided depending on the resource that are needed. And our team that works on that could provide additional detail at a later time, and we'd be happy to report back on an additional detail. But there are different requirements and assessments for each of those resources.
Are there, what are the job protections and what is within our purview to impact there? Because as one of you said earlier, that one of the reasons that people will infrequently refuse to test is that they're worried about losing their jobs. Are there, what kind of protections are in place for people who find themselves in that situation?
I'll ask Doug to speak to that. Doug, are you able to speak to that?
Sure, yeah. So in addition to quite a broad array of income and job protection supports that pre-existed our experience with this pandemic. Literally in the last few weeks and months, there have been a number of significant changes in federal and state law that in many ways address some very long-standing and well-known gaps in support. So just, I want to list three. One of them is, of course, the Families First Coronavirus Response Act, which added, essentially for the first time at a national level, emergency paid sick leave. In addition, it also offered an extension for the FMLA leaves, and I'll talk about that in a minute with some additional enhancements. And then there's also been some recent changes to unemployment insurance to basically sweep in people who have traditionally not been eligible for unemployment insurance, as well as just a few weeks ago, changes that Governor Newsom implemented with regard to the workers' compensation program. So if you don't mind, I can just give a little bit more detail on all three of those.
Please do. Thank you.
Sure. So for the Families First Coronavirus Response Act, or FFCRA, so it has this emergency paid sick leave. And what it offers is that if you are to be a qualifying person, and again, there's all sorts of different criteria, size of employer, et cetera, but just if you meet the basic eligibility criteria, if you are subject to a federal, state, or local quarantine or isolation order related to COVID-19, that you've been advised to self-quarantine by your healthcare provider, that you yourself are experiencing COVID-19 symptoms, that you're caring for another individual who might be subject to isolation or quarantine, or you're caring for a child whose school or place of care is closed for reasons related to COVID-19. For all people who fall into those categories, so long as they're working for a covered employer, they get 2 weeks, up to 80 hours of paid sick leave at their regular rate of pay. So that is, and obviously there are some caps on income and things of that sort, but that's pretty substantial from my perspective. As you may well be aware, the Family and Medical Leave Act that was enacted, in 1993, I believe, it's been with us for a long time, but frankly, its promise of supporting people in times of need and in times of leave has been a little bit unfulfilled, in the sense that, sure, it's great to have 12 weeks of job protected leave, but unless you have 12 weeks of savings or 12 weeks of sick leave or vacation leave or other paid time off that you can rely on, it hasn't been a benefit that most people have been able to fully realize in their time of greatest need. So this is a pretty substantial improvement. Now, it is time limited. These are only lasting essentially for a few months while this pandemic is going on, but it's still a pretty significant change. Some other changes are paid sick leave to take care of a child whose school or childcare provider is closed related to COVID-19. For that type of sick leave, you can get up to 2/3 of your rate of pay. And then there's also an additional 10 weeks of paid and family medical leave at 2/3 of the rate of pay, again, for childcare needs. I understand, obviously, summer camps and other supports are coming back online, but those are 3 different types of supports just in that federal law that are going to make, hopefully, a big difference. Then on the unemployment insurance, certainly with one of the big, let me just back up a little bit. Unemployment insurance is a wage replacement program, meaning you have to be a wage earner. So if you are in business for yourself, or if you are an independent contractor, whether you've been correctly characterized as such or not, the bottom line is that independent contractors, people in business for themselves, are not viewed as wage earners. You're essentially running your own business. You're earning profit, if you will. So those folks have been traditionally outside of the wage replacement system that we have in unemployment insurance.
But
Now,
Doug,
because, yeah.
I'm so sorry to interrupt. I want to make sure I get to ask all of my questions, but this is important. And I wonder if you would, in an off-agenda report to the board, give us this outline. You said a lot of important things. I'm worried that I might not remember all of them, and I think that these are also questions that are going to come up frequently. But I want to try to get in just a couple more questions, but thank you so much. That really is critical. So I'm interested to know, and this is back to Evelyn and Sarah, both our current plan of what agencies or providers are currently teed up to provide support for food, transportation, childcare, elder care, or other services, and how they're being mobilized now. But I also want you to answer at the same time or address a concern that I have in the May 26th report, COVID report. There was a note that after July 1st, the county would step away from coordinating supports that are critical, I'm just reading from the report, that are critical to reducing coronavirus transmission across the whole county. And certainly, given the potential massive cost, I understand that shared funding is needed. But can you talk about what's happening now and what kind of coordination on funding and partnerships we're looking to post July 1st?
Thank you for the question, and we recognize the importance of really identifying how the isolation and quarantine supports work and what agencies we're working with. The best group to speak to that would be our Health and Human Services group within the Emergency Operations Center. And so I will need to, we'll have to defer to them to provide the additional information about the mechanics and supports and the plans around the isolation and quarantine supports. We work closely with them, but we're not the best folks to represent for those questions, so we can take that back.
And excuse the interruption, Supervisor Ellenberg, but I think if we could ask for that as an off-agenda report in writing as well, that would be helpful. That would allow us to take the subject matter content from staff and have it side by side with the more legal analysis from Mr. Press and his shops. Forgive the interruption.
Well, what I'll do then, Evelyn, thank you, is use my last minute or so to add a couple of requests to that off agenda so that they are all in one place for you. I requested at the May 26th Health and Hospital meeting that more detailed information on status and progress of this work be added to the indicators webpage. The ledge file provided today includes this current information, hopefully broken down by source. But I would like to see, and for the public to be able to monitor, the current workforce compared to the targets each week and number of cases per day that can be managed with that capacity. And my final request is that as we get to a critical mass in this workforce, I'd like to request an analysis of the demographics of the contact tracing workforce, which might include city of residence and languages spoken. Certainly, and I know that you agree with me, our tracing workforce should be generally representative of the community with an overrepresentation of groups that are disproportionately impacted by COVID-19. Is all of that clear?
Yes, thank you.
Okay, fantastic. Thank you. Oh, we are at 20. Thank you so much. I really appreciate everyone's responses.
Thank you, Supervisor Ellenberg. Let me just toss excuse me, some very specific questions out and ask whoever is equipped to respond to just sort of lean in and see if we can get relatively quick answers. On this first one, though, I do think I'm probably going to go to Ms. Ho, which is we've talked a lot about the challenges of ramping up the numbers to get to 1,000 folks over a period of 10 weeks, perhaps. And you did a very nice job of sort of laying out that path. But in recent days, it appears to me that excuse me, that we may be that staff may be thinking that number is ultimately going to be proved to be more than are needed by virtue of relatively more modest case counts. Could you help me on that one?
Thank you for the question. We are planned with additional capacity built in within the calculations. So when we looked at a projected potential case count number based on potential growth rates that we might see, and we look at the time required to investigate each case and call each contact and do the associated documentation, we built in buffer space. With the expectation that one, new individuals coming on board would have lower efficiency initially. Two, there would be some degree of workforce turnover as we progress in months, and so there would be some churn there and some loss of efficiency there as well. Additionally, from a public health perspective, it is better that we are overstaffed and stay on top and ahead of all the chains of transmission as much as possible. And so we wanted to be particularly aggressive in the number of the workforce required, knowing that, for example, the state's target of 15 tracers per 100,000 would equate to basically 300 tracers. Our 1,000 workforce also includes the clinical supports, the team leads, and the data entry. It's a rounded team, and so it includes all of that workforce.
But that being said, just to be clear, we might get to the point where we've hired 600 people and you tell us not to worry that we haven't gone to 1,000 because 600 is adequate given the caseload we're experiencing, yes?
Yes, we may adjust quantities over time as we build efficiency. So the target numbers that are laid out are meant to be a conceptual growth plan, and those targets may be adjusted as we move forward.
Thank you. In one of the slides earlier that you put on, I noticed that a person who is deemed to be a contact, if I read the slide correctly, will not be told where they may have been exposed to COVID. Did I read that correctly?
So in general, we always try to provide the minimum amount of information necessary to ensure the safety of someone. So if we are able to do so by protecting who someone was exposed to and where that happened, we will do so. If there are instances when we find that that's impossible and still able to understand who was exposed and protect those people exposed, there may be instances where the public health department or its proxies may disclose that information. So it may vary on a case-by-case basis, always with the principle of protecting privacy wherever we can do so while still protecting safety.
And I'm just curious, because you've stressed, and it's been helpful to understand, the sort of approach, the cooperative approach rather than coercive approach. So when you call someone who's been a contact and say, hi, we believe you may have been in contact with someone who had COVID, but we're not in a position to share the information about who that contact was, does that impede your ability to make progress? I would imagine, I'm just not having been in that situation, that somebody would immediately want to know, oh my goodness, where was I exposed? What was the nature of the exposure?
So Supervisor, that's an excellent question. I think we face that in two ways. One, we train our teams to handle all range of those circumstances, and try to explain to people how we want to err on the side of protecting their health, and we want to urge them to do the same. What we find realistically, though, is the vast majority of people are more concerned about their health than knowing exactly what happened, and so they are often willing still to comply with our recommendations to help protect their safety without knowing all of the information that we might otherwise be able to share. I think I would just add, well, I'll stop there.
Let me ask a question more specifically that I asked in the first panel about what the definition of contacts is for purposes of follow-up. So your effort will be, of course, to reach out to people who had a contact that is the basis for concern and follow-up. So what's a contact?
Sure. So I think as Dr. Rutherford described, this has been a bit of a moving target as we learn more and more about this disease from our starting point of knowing absolutely nothing about it and just basing our assumptions on principles of similar diseases in the past. We are also moving towards coming in line with the CDC's most recent recommendations of describing a close contact and therefore a contact with the likelihood of transmitting disease or a possibility of transmitting disease as people in the same space at 6 feet or closer for 15 minutes. Now, previously, there had been recommendations to use a slightly longer or slightly shorter time frame. And so some of our policies and training still reflect those, what now seem very old, but are probably a week or a month old recommendations to use slightly different time frames. So in general, we're coalescing around 15 minutes times 6 feet with the understanding that this is our best interpretation of the science as we know it right now. Also, there may be circumstances where we deem them to be of such high public health importance that we take an even more conservative stance, especially in places like skilled nursing facilities or custody settings, where we decide to consider on a case-by-case basis certain shorter interactions or otherwise more protected interactions as still with the potential to transmit disease and treat it accordingly.
Thank you. That's very helpful. I will just say for all parties, I think it's entirely understandable that criteria changes as we learn more on a day-to-day basis, sometimes almost an hour-to-hour basis. But I do want to communicate to you all as someone who works with his constituents that that is something that's not always apparent to the public, and that when they get what they hear as conflicting information or changing information, it has the potential to undercut credibility and effectiveness. So I think very helpful, for example, for you to share, well, look, we have more information now. Because we have more information now, the numbers and approach have changed. Because what I hear a lot from folks in calls and emails and other communications is, you told us one thing last week and you told us another thing this week. How am I to believe any of it? And the answer, of course, is we know more and circumstances have changed. But I do think you're going to need to be somewhat repetitive about that in some respects so that people understand why they are hearing one thing one week and another thing a following week. It's a tough communications challenge. I was interested in asking some additional questions about essentially the support systems that are available for folks who are either isolated or quarantined. But I think, Mr. Price, you covered much of that, and I'm looking forward to the off-agenda report. And then the same with Ms. Ho and the rest of the team with your off-agenda report responding to Supervisor Ellenberg's questions as well. Let me just ask, there was a conversation or some information about making sure folks were sort of culturally competent, linguistic, understood the communities and so on. How much of that is geographic? I've raised this issue before, and it frankly has, I think, been perceived as an administrative challenge or impediment in terms of working with all the moving parts and pulling together a team like this. But isn't there value in, and you can tell my predisposition from the way I phrased the question, isn't there value in having somebody follow up on a Milpitas person if they are from and of Milpitas and know the lay of the land there? I understand that we're not talking about shoe leather work here, but if somebody's in Milpitas and they've had contacts, the greater likelihood, it seems to me, is that they're going to be Milpitas contacts as opposed to Gilroy contacts for the sake of discussion, and that having somebody doing the outreach from Gilroy who's not familiar with Milpitas has the potential to be problematic. Or am I overestimating, in your judgment, the value of local knowledge on a community by community basis? I ask this question because there are 15 very different cities and towns, everything from a community of 3,500 to a community of more than 1 million. And South County is not North County, and West Valley is a different place as well. So who'd like to lean in on that one? Maybe Ms. Ho or Dr. Rudman?
Sure, this is Evelyn. I'll begin and I'll pass it over to Dr. Rudman. when we think about the questions that we are asking of our contacts and of the cases to find out who their contacts are, most of it is actually just jogging, as stated earlier, jogging their memory with memory aids of where they have gone. And for most people, that is generalizable for the large part. Most people's activities are generally, I've been to the grocery store, I went to this service, I went to that activity. And so I think to some degree, a more standardized approach across the county, it doesn't require hyper localized information. There are some settings and within some communities where the ability to elicit that information requires that cultural competency, that trust building, and that understanding in terms of communication, in terms of approach, and in terms of style. And so I think that is an area where we are in particular looking at ensuring that our workforce is representative of our county population demographically, and also with deep community knowledge in some of our areas of disproportionate impact. This is especially important when we think about the quarantine and isolation supports that are needed. So for example, an individual who doesn't need particular isolation and quarantine supports and is able to easily do so, those instructions could be provided by anyone generally who is trained and proficient at doing this work. However, to understand the unique sets of isolation and quarantine supports needed among some communities, whether it's due to overcrowded housing, being an essential worker, and those other factors, being able to comprehensively ensure that we can get that information, elicit that information, and meet that need is the area that we would really want to have hyper-localized and knowledgeable workers specific to that area. And so that is a strategy that we are continuing to explore and build out. First, in the workforce part, ensuring that part of our workforce is coming and drawn from those communities. We want to provide job opportunities and ensure that workforce there. From there, additional strategy, whether it be shoe leather approaches, could continue to be explored as we better understand the needs. And I did want to mention also, if individuals are traveling or are exposed in specific settings that may be a particular public health concern, we have an entire specialized investigations unit that Dr. Redmond can speak to that would work on individuals who are going to a particular type of large group setting or a setting of particular public health concern.
Let me ask you to hold off on that if you would, please. I do want to just, notwithstanding the answer, also underscore the potential value of using local folks in individual communities in that if, depending on how your recruitment efforts go, if you're asking this city or that city to provide some repurposed, as Dr. Rutherford described them, repurposed public employees, I could imagine that any number of our cities would be perhaps somewhat more motivated to provide some of their own folks if they knew that the follow-up was going to be in their communities. So there may be some additional incentive there if we tell the folks in Gilroy or Milpitas or Campbell or anywhere else, hey, if you can share some folks, we'll make sure that those folks get dedicated to your community. I understand it's a countywide effort. I understand that we're all in it together, and you may not have the recruitment challenges that require that, but I just want to toss that into the mix as well. Could someone describe briefly what the vetting process looks like? And I don't know if this is a Haluna question or a question for our county team, but it does strike me that this is going to be important as you hire potentially as many as 1,000 new folks over just a period of a few months, that that we make sure that we are not in a position where people who are not appropriate are handling confidential information, HIPAA protected information. I see Mr. Dale leaning in. Do you want to share some thoughts on this with us?
Sure, I can start. And to clarify, as described, the mix of the 1,000 workforce is volunteers, DSWs, and paid staff. For us, we're going to be hiring 95 staff, which includes leads and case investigators. And through the vetting process, which starts with the County of Santa Clara, and been designed together to certainly reach out to volunteers who are interested in being part of this contact tracing efforts, asking a series of questions anywhere from, their commitment. Can they work 32 hours? Can they have the necessary equipment because they have to have their own laptop, as well as the ability to have an internet provider because they're working remote, to the variety of criteria that's then handed over to us once the county signs off on a volunteer agreement, which covers the requirements of HIPAA and the protection of confidential information to ensure that they also, once they step into going through the training process, that they also receive privacy training, HIPAA training, and they understand the requirements of keeping that information confidential and ensuring that the protection of those folks that they do contact out in the local community.
And what about a background check of some type? How does that fold into the vetting process?
Yes, there is a background check as part of this, and a link is provided with the county where that's part of the process of vetting. And then, of course, if something were to pop up on their background, we would take the appropriate action to either it's a volunteer, mostly a volunteer, and or a paid employee. And then, of course, in regards to the paid employees, I have Tim Seifert here, the Chief HR Officer. Tim, can you just describe really briefly what our vetting process comes to when it comes to recruitment and hiring, actual hiring of individuals for leads and case investigators?
Sure. Thanks, Peter. Supervisor, as Peter has said, we have 90 that are in our contract that we'd be hiring. We're focusing mainly now on, it will eventually be 50 contract tracing leads. And so for those folks, we have 6 of we'll be in the 3rd week next week. And so our commitment was to have our leads on staff by then. So we have 6 that are starting next Monday. And so the vetting process for the initial group has been for those folks that have had a background in public health, they've had contract tracing experience, they've led teams. That's kind of the criteria we're looking for those. We haven't yet, because most of the workforce doing the tracing that is going to be done by volunteers. In our contract, there are 35 tracers. In agreement with the folks that we're working with on the contact tracing team, is that we've kind of held off on posting that because we don't want to post a paid position when we're searching for volunteers. Those paid positions, we've agreed that will be kind of specialties if we need folks that can speak a certain language, that can communicate in a certain way, or that we have to have a tracer that with certain skills.
Let me just interject here, and Dr. Rudman and or Ms. Ho, if you want to chime in on this. Here's my concern, and I want to state it very clearly on the record and express my expectation that these issues will be thoroughly addressed. We are in an unusual position in terms of ramping up 1,000 employees. I think I can make Supervisor Ellenberg smile if I say I know how long it usually takes us to hire 2 people for an important position. See, I could in the county. And so, we literally can sometimes go a couple of years trying to open a couple of positions, get folks hired. And here we are now saying, gee, we're going to have 1,000 folks potentially in the matter of weeks teed up, ready to go, handling very sensitive information, representing our county, reaching out to any segment of our 2 million county residents. I just think we need to be very clear that the vetting process has to be thorough enough to make sure that we don't have new hires, quick hires in the system who are inappropriate for dealing with the public by virtue of criminal background or any other misconduct that should send up a red flag. And I know that to some extent that's at cross purposes with the speed with which you're trying to ramp up everybody. But, we can't send 1,000 people out there into the community because I'm looking now at Mr. Press, and I'm thinking I can get him to frown when I say legal liability for sending the wrong people out into the field as county employees is a source of concern. So, Dr. Ho and Dr. Rudman, Ms. Ho and Dr. Rudman, if you will just at least indicate you heard that loud and clear, that would be some reassurance.
Absolutely. This is Evelyn. And to that point, we are, that's why we are prioritizing the county workers initially in terms of the deployment. So I wanted to contextualize the number of volunteers. Out of the 962 who have completed the kind of the second steps, they have signed some agreements, they have certified to become a disaster service worker. That 926 is drawn from a pool of nearly 3,000 volunteer applicants. And so we have already done some initial triaging from there. So we are not necessarily inviting everybody who comes through, doesn't automatically walk through the door all the way. So we are prioritizing those who have skills and the skill sets required and the time and availability. From there are additional steps that must be taken, including a background check. And then as we hand them over to Haluna, they do additional vetting of their availability and skills and equipment and resources. Then volunteers then complete the trainings. At the end of the trainings, there are also skills and knowledge assessments involved. And so over time, we do see significant attrition through that pipeline that allows us both either we do it or the volunteer does it themselves to continue to refine the workforce that we are engaging to the highest quality possible. But I hear and understand your point.
All right. Well, thank you. Go right ahead.
I just wanted to add two components. One, Evelyn alluded to the extensive skills checks and observation that would occur after someone is deemed appropriate to start the work. We have an extensive period during which one of the more expert folks will actually listen in with them or work with them during their first calls to really ensure that not only have they completed the training and appear on paper to meet all of our qualifications, but that under observation they're both providing the high quality services and representing the county with the exactly the ethos we would want a county employee to put forward. And then finally, the incidents of the absolute highest public health import do remain within county purview under the public health department by being routed to the special investigations team, who focuses on instances of the highest sensitivity or the highest risk for disease spread, whether that's a jail setting or a skilled nursing facility or a large community event.
Thank you. I'm going to close with one last question, probably for Ms. Ho and Dr. Rudman, and that is, all of this, of course, depends on testing capacity. Dr. Rutherford in the first panel did a nice job, I thought, of reminding us all that it's not just the testing to identify folks for contact tracing, but then, of course, you got to test the folks that you identify through the contact tracing. We had shot for a number like 4,000, sometimes called 3,800 by May 31st. In our board meeting this week, it sounded to me like we were more like at 2,800. So what's the relationship between our testing numbers and the need to boost them and your ability to get the job done on contact tracing?
This is Evelyn. So as mentioned in the legislative file too, in that image, that you're exactly right, that the testing, case investigation, contact tracing, and isolation and quarantine supports live in an ecosystem together. They're all interrelated. And so testing is a critical aspect, but it's not necessarily the only totally dependent entryway, right? And so because there's a feedback loop between case investigation, contact tracing, and testing, while we need to increase our ability to test within the system and within the county, as we identify contacts, for example, continue to ensure that contacts can be tested. But actually the most important part, and some early other research has shown, that ensuring that contacts are quarantining actually is probably the most critical key. Because then regardless of if they're tested or not, their ability to quarantine becomes how we break the chains of transmission.
All right, thank you for that. I'm going to ask Supervisor Ellenberg if she has any last comment or question. I know sometimes you're looking surprised. Just want to make sure you don't have one more thing as we sometimes do, before I thank the panel and wrap it up. Supervisor?
I really appreciate all of this information and look forward to the follow-up. Thank you all so much for making time.
Thank you. Well, then let me thank all of you who took part in this second panel. Mr. Seifert, delighted you were there to be phone a friend for Mr. Dale when the time came. So glad we were able to make that work. And appreciate all the work you're doing and your availability today, folks. Thank you all for being with us. Take care.
Thank you.